Gastroesophageal Reflux Disease, or GERD, is a common complication that can arise after sleeve gastrectomy, which is currently the most widely performed metabolic and bariatric surgery worldwide. Many patients and clinicians are concerned about the possibility of GERD symptoms worsening, persisting, or even developing for the first time after this procedure. The medical literature presents mixed findings regarding how often GERD occurs and how severe it can become following surgery. In this video, we'll explore why GERD happens after sleeve gastrectomy, how it's assessed and managed, and what long-term risks patients should be aware of. Sleeve gastrectomy is a surgical procedure designed to help with weight loss by removing a large portion of the stomach, leaving behind a narrow, tube-like structure. This surgery is popular because it's effective for significant weight reduction and improvement of metabolic conditions. However, altering the stomach's shape and size can impact how food and acid move through the digestive tract, which may increase the risk of GERD. Understanding the anatomy and function of the new stomach is crucial for recognizing why reflux can become a problem after this surgery. After sleeve gastrectomy, the prevalence and severity of GERD can vary widely. Some studies report that GERD symptoms improve in the short term, but others show that new or worsening reflux can develop in a significant number of patients over time. This inconsistency in the data makes it important for both patients and healthcare providers to monitor symptoms closely and be proactive about management. The risk of developing GERD after surgery is not the same for everyone, and individual factors play a role. Before undergoing sleeve gastrectomy, a thorough preoperative assessment is essential. However, there is no global consensus on the best way to evaluate GERD risk before surgery. Current recommendations, including those from the International Federation for the Surgery of Obesity and Metabolic Disorders, suggest routine upper gastrointestinal endoscopy. This is because a high number of patients, even those without symptoms, may have findings like hiatal hernias, esophagitis, or Barrett's esophagus. Identifying these issues early can help guide surgical planning and reduce postoperative complications. Upper gastrointestinal endoscopy is a valuable tool for detecting potential problems before surgery. Even patients who do not report any symptoms may have significant findings, such as hiatal hernias or inflammation of the esophagus. By identifying these conditions, surgeons can make more informed decisions about how to proceed with the operation and whether additional steps, like hernia repair, are needed. This proactive approach can help minimize the risk of GERD after sleeve gastrectomy. During sleeve gastrectomy, it's important for surgeons to check for and repair any hiatal hernias they find. Studies have shown that repairing these hernias at the same time as the sleeve procedure can significantly reduce GERD symptoms and improve esophagitis outcomes. This step is now widely recommended as part of the surgical protocol, as it can make a meaningful difference in the patient's quality of life after surgery. In the short term after sleeve gastrectomy, many patients experience an improvement in GERD symptoms. This period of relief is sometimes called the window period, which typically lasts about 2 years. During this time, the new stomach anatomy and lifestyle changes may help reduce acid reflux. However, it's important to remember that this improvement may not last indefinitely, and ongoing monitoring is necessary. After the initial window period, GERD symptoms often return or develop for the first time in many patients. Studies estimate that de novo GERD, meaning new onset reflux, occurs in 30% to 60% of patients after sleeve gastrectomy. This highlights the importance of long-term follow-up and symptom tracking, as the risk of reflux increases over time. Patients should be aware that GERD can become a chronic issue requiring ongoing management. GERD after sleeve gastrectomy can occur for several reasons. The surgery changes the shape and pressure dynamics of the stomach, which can make it easier for acid to flow back into the esophagus. If a hiatal hernia is present and not repaired, or if there are strictures or other anatomical issues, the risk increases further. Understanding these mechanisms helps explain why some patients develop GERD postoperatively, even if they didn't have it before. When GERD symptoms develop after sleeve gastrectomy, the first step in management is usually lifestyle modification. This includes dietary changes, avoiding foods and drinks that trigger reflux, and stopping smoking or alcohol use. In addition, acid-reducing medications like proton pump inhibitors are commonly prescribed. These measures can help control symptoms for many patients, but some may require further intervention if symptoms persist. For patients whose GERD does not improve with lifestyle changes and medication, conversion surgery may be considered. The most effective option is converting the sleeve gastrectomy to a Roux-en-Y gastric bypass. This procedure has been shown to resolve GERD in 66% to 100% of cases, especially for those with severe or refractory symptoms or Barrett's esophagus. It's a major decision, but for many, it offers significant relief and improved quality of life. Sometimes, GERD persists because of anatomical problems such as a retained fundus, strictures, or an untreated hiatal hernia. In these cases, surgical correction of the underlying issue can help resolve reflux symptoms. Identifying and addressing these problems is an important part of the comprehensive management of GERD after sleeve gastrectomy. One of the long-term concerns after sleeve gastrectomy is the development of Barrett's esophagus, a condition where the lining of the esophagus changes due to chronic acid exposure. Studies show that the incidence of Barrett's esophagus ranges from 4% to nearly 19% over more than 5 years of follow-up. Because many cases are asymptomatic, routine endoscopic screening every 5 years is recommended for all post-sleeve patients. A major concern for patients with Barrett's esophagus is the potential risk of developing esophageal adenocarcinoma, a type of cancer. However, current evidence does not confirm a direct link between sleeve gastrectomy and increased rates of this cancer. Ongoing research is needed, but for now, the focus remains on regular monitoring and early detection of any changes in the esophagus. In summary, GERD is a frequent and sometimes serious complication after sleeve gastrectomy. Careful preoperative assessment, intraoperative vigilance, and long-term follow-up are all essential for minimizing risks and managing symptoms. Lifestyle changes and medications are first-line treatments, but some patients may need additional surgery or correction of anatomical issues. Regular screening for Barrett's esophagus is important even in the absence of symptoms. By understanding the risks and management strategies, patients and clinicians can work together for the best possible outcomes.